I have to unmute this one. Sound good? All good? Okay, good morning, everybody. Thank you for waiting. Sorry about the delay. I'm Chelsea Pelche, for those of you I don't know. I'm from the School of Health Sciences here at UNBC. Thank you so much. It's great to see a big turnout for our final health research seminar of the semester and to support our students who are presenting today. My computer does not seem to be advancing far.
Just breathe, Jill.
Make sure you hit the cursor on the screen first. Okay.
Oh, there we go. Thank you. Sorry. So we want to thank, we have a few sponsors who support this seminar series. If you're not aware, this is a series we run throughout the school year. Every month we have a different speaker who we ask to come in. So we have sponsorship from the School of Health Sciences, Nursing, and Social Work, as well as the Northern Medical Program on campus, and then and the Psychology Program. And then we also have received some funding and support from Sun Life Financial that enables us to provide this seminar series every month. If you have any questions or follow-up concerns, please address them to Rachel or Bree at the Health Research Institute. The recording of this presentation may or may not be available, I'm not sure, on the website. But on the website, the previous seminar series presentations are definitely available, as well as you can see our schedule of upcoming speakers. We're currently starting to think about what speakers we will have starting in September and through next year. So stay tuned to that. And if you're not already and you want to get on the Health Research Institute mailing list, that's also a good way to stay informed of the presentation. So today we have our honors students. So for those of you who aren't aware of how the Health Science Honors Program works, students can apply. It's a competitive entry program, and they apply typically at the end of their third year, and then they are accepted into the honors program. And this is a specialized, essentially, health sciences degree. They complete an advanced research training in a seminar course, and then they complete an independent honors research project with an honors supervisor, which entails conducting a research project from start to finish, writing a thesis, which I'm sure they're all busy with right now, and as well as doing a presentation, which is what today sort of serves as. So there is 6 presenters today. This year we happen to have an exceptional crop of honors students, and the most honors students we've ever had. So it's kind of an exciting year for the program. And so I'm very excited that they're all here to share their projects with you today. They've each been asked to prepare a 10 to 12 minute presentation, and then there will be a couple minutes for questions after each presentation. And then at the end, we will have some more time for discussion in general. If you have questions for the students, I'm sure they'll be happy to answer them. So that's all for me. First up, I will call Kirsten Ward to come and present. Let me see if I can figure this out.
This morning. I'm really excited to start things off with the work that I've been doing over the last 8 months, which, as this really long title says, has been looking at the facilitators of physical activity among older adults in Northern BC. Specifically, I've been focusing on the Active Health Solutions program that's right here in Prince George. So to start off with, I'm going to kind of set the context, let you know what the problem is, where the gaps in the literature are, and move forward into what I wanted to do about it and where I wanted wanted to go, take a quick look at my research objectives, the timeline, and a very, very brief overview of the methods that I did. Then we'll go into the interview results, look at the themes and the sub-themes that emerged from the data, and finally look at what does this mean and why it was important to get this information at all and how we can move forward with it. So to start, what's the problem? Well, physical inactivity is a huge problem worldwide. It's currently the 4th leading cause of death globally, which results in about 5 million deaths per year caused by physical inactivity. That's huge. And so these huge statistics have brought a lot of researchers together to try and figure out why this is and how we can fix this. So a lot of the literature in this area looks at the barriers or reasons why people are unable to be physically active, and the facilitators, or why people are able to be active and what supports they have for this. It also has a real focus on initiation, or the beginning of a physical activity program or regime, and not so much focusing on the maintenance or keeping up doing this. So we found that it's actually we're pretty good at getting people into programs and being physically active, but it's a lot harder, and we're yet to really find a good solution for how to keep people in this. The other gap that I've really noticed while digging into this literature is that there's not a whole lot about northern, rural, and remote regions. So Prince George is a northern community. We're fairly isolated from the large urban centers such as Vancouver, and there's not a lot that's known about this topic in regions like Prince George. So in all of Canada, there was exactly 2 papers, one in Newfoundland and one in Saskatchewan, that covered this topic specifically. The other thing that I want to introduce is the demographic that I'm looking at. So I'm looking at older adults, and this is because the physical inactivity is a huge problem for this group in particular. Less than 15% of Canadian older adults are actually meeting the GAP guidelines for physical activity, which is the 150 minutes per week of moderate to vigorous activity that you've probably heard about. And this may be due to the increased number of barriers that they face, a few of which are listed here. And to add on to this, if you're in the geographic regions that I mentioned, northern, rural, or remote cities, you have even more barriers that you're trying to get over in order to be physically active. So things such as the weather, which thankfully we're coming into a nicer season here, but that can be a huge barrier to being physically active for everyone, but particularly for older adults. So now that I've kind of presented some of the problems, I want to find a solution, and that's where Active Health Solutions really comes into play. So this is a program based in Prince George that looks at designing physical activity programming for older adults who want to maintain, regain, or improve their physical activity levels and their overall health. So this is a great program, and they've had a lot of success, with some of their participants being upwards of 10 years with these instructors. That's huge, and that's a really great way to measure success of a program for these individuals. So between the big gap and the problems that we talked about with the physical inactivity and this amazing solution, I couldn't help but want to dig a little bit further to find out why this works and how we can transfer some of this information to make more programs and better facilities available for this demographic. So I've done a qualitative research study that has looked at determining the facilitators of physical activity maintenance in this group of highly active older adults. And then I had also a couple secondary objectives, which was specifically looking at the Active Health Solutions facility and looking at those characteristics, as well as looking at the context of Prince George specifically. So a very, very brief outline of the methods. So over the last 8 months, this has kind of been what's gone on. And I'll draw your attention briefly to the inclusion criteria. So I looked at older adults who were over 60 years of age. This was the most common cutoff for the older adults category as per the literature. As well, I wanted to look at people who were with Active Health Solutions or the instructors for at least 6 months, because this is commonly the cutoff for if you're going to drop the program, this is likely when you're going to drop it by, with rates of about 50% of people dropping out, usually by the 6-month mark. I conducted 9 semi-structured interviews, and I'm really happy to say that I actually had a lot more interest in this than just 9 people, but due to the time constraints of this project, that's all that I could fit in. So moving forward, after I'd done the interviews, I transcribed them and assigned pseudonyms, so as we go on to see the results, there will be some quotes to illustrate the points, and I will mention names, but they are the pseudonyms, not the actual participant names. And then I got to have a very steep learning curve with my qualitative methods and learn how to do coding. So I used an inductive approach to really draw the things up from what the data was telling me, with some elements of grounded theory in there. And I also got to have very colorful walls with sticky notes as I did this by hand. So what is the results of this? What's the real need that we found out about this? I found 3 main themes that are underneath the older adults here, and they each had some sub-themes that they're telling you about. So the first one was healthy aging. So this was really looking at what the factors were that helped these people be physically active at that age point, and how being at that time in their lifespan really interacted and impacted their physical activity and their healthy aging. The second one was the context of environment. So this was looking at the personal contextual factors that really impact and allowed or were challenging for the individuals to be physically active. And the final one was social connections. So this was looking at the social aspect of it, really focusing in on all of their interactions with peers, with the instructors, family, friends, you name it. So let's dive a little bit more into this and look at the first theme of healthy aging. So this one had 4 sub-themes underneath it. The first one was wanting to age well. So most participants shared with me some sort of story about a friend, a family member, or someone else that they know who was aging very poorly as a result of not being physically active. This then helped them to see physical activity as a tool to be healthy as they aged and to avoid those really negative consequences. The second one was personal journey. So a lot of people were sharing the fact that they've been active to some degree throughout their lifespan with, maybe their parents started them in sports as a little kid and that kept them through. The third one was feeling safe. So this one really tied into the facility and the Active Health Solutions program, where they felt that it was very safe to go. They weren't going to get injured when they were told to do a certain activity, and they felt very comfortable going to this place. And the final one that had the most impact for me in this category was doing other activities. So every single participant shared with me that the physical activity they were doing and the help that they were able to get as a result of this let them do other daily activities or other activities in general. So whether this was that they wanted to run a marathon, or they wanted to go on a hike, on a vacation, or just being able to tie their shoes in the morning, this had a huge impact. And Deborah really summed it up, and this was a really impactful quote from me, was that she has a very young grandson, and she's now able to kneel down on the floor and play with him, which was not something she could do before because of the pain that her knees caused her. And this was huge for her. The second theme that I wanted to dive into was the context of environment. So this included 3 sub-themes, the first one of which was integration. So really planning and scheduling the physical activity and making goals for themselves, achieving those goals, feeling the success and wanting to keep going. The next one was enjoyment. So this included the enjoyment of the physical activity itself, as well as the whole experience. So a lot of the times that was the social aspect as well. And finally, the knowledge. So the knowledge was actually quite a large sub-theme. It involved the participants' knowledge of their limits and what they were able to do, as well as the instructors' knowledge about working with older adults and being comfortable with that, as well as their knowledge about what the city had to offer. So Alice really summed this up well by saying, the opportunities of Prince George are pretty darn amazing. And she goes on to list some and says that it's fantastic. So this really showed she knew what was out there that she was able to go and do in addition to the Active Health Solutions programming. And this knowledge really let her live a overall physically active lifestyle instead of just going to her class. And then the third theme was social connections. So this one had 3 sub-themes as well, the first of which was atmosphere. So I already touched on this a little bit with the feeling safe, but participants all mentioned that they felt really good going to the Active Health Solutions facility. It was comfortable, it was laid back, they didn't feel judged, and they didn't feel a need to be competitive with their work. And this was really huge in getting them through that door time and time again. The support network was also mentioned, so whether that was family, friends, peers in the program, coworkers, you name it, people were supporting them in their activities. So this was support in the form of encouraging them and saying, hey, you're doing great, like you're a great role model for your kids, this is awesome, to actually going and doing the activities and saying, hey, do you want to go on a walk together? Let's go for a run. And then the final one was the instructor personality. So again, all of the participants mentioned that the instructors were really encouraging. They loved what they did, and it inspired the participants to be physically active and keep going back. They had a lot of fun. And Irene sums this entire theme up very well with this quote, saying that the instructor knows the history. There can be 6 of us doing something, 3 of us are doing them different because she's adapted them. There's no embarrassment. There's no thinking, oh my God, I can't even do this. We have so much fun. And this was a really impactful quote that I thought summed that up very well. So now that we've kind of gone over all that, what does it mean? Well, we can kind of break it up into some categories here. So we can look at the individual, facility, and community levels, and they each have some of the themes and sub-themes that I chatted about. And then these can then be applied to improve programming to help individuals be more physically active. And I'll just give you some examples here. So for the individual, finding active social groups, such as a walking group, to keep you accountable, to get that social interaction, and to enjoy what you're doing. At the facility level, we could educate instructors on the details of physical activity for older adults so that they feel really comfortable, they feel safe, and they feel like the person who's teaching them really knows what they're talking about. And finally, on the community level, something like providing an informational pamphlet about the trails. This could be super helpful in that, you know, if you're out running errands and you've got 20 minutes before you need to be the next space, you could go behind, you know, Art Naps and go for a walk. That was actually one of the examples that a participant shared. So things such as this are a great way to incorporate physical activity, not only into programs to maintain participants, but also into their everyday lives to improve the physical activity of this demographic in general. And I have some beautiful references for you, and I wanted to thank you all for listening. And if there's any questions, I think I have time for a couple.
Questions for Kirsten?
I will ask you a question. How would you encourage seniors that maybe aren't active right now? So did they give you any ideas of what you could do to encourage people to get out of their homes and go to these things?
I didn't really focus on that too much because a lot of the literature does, and previous research does explore how to get people active. But a lot of them had said, you know, they took a break at one point or another in their life and went back to physical activity. And it was a lot of the same factors. It was something they were comfortable doing. They were recommended and it sounded good. They had a friend who was already doing it and they said, hey, like you should come with me, and they went and loved it. So, things like that.
I'll ask you a question. Why did you choose a qualitative approach to answer your research question?
Yeah, so I chose a qualitative approach because it really let me explore in depth the themes and the facilitators that older adults had for physical activity, whereas something like a quantitative approach wouldn't have gotten that in-depth perspective that they were able to share through this.
Excellent, thank you. All right. Next, oh, Molly. How does the cookie thing work? Oh, yeah. So next we have, sorry, we have a slight change of format. So next we have Molly Brawdy presenting her project on glaucoma patients. Okay, thank you. So like Dr. Peltier said, my name is Molly Brawdy, and I did my thesis project on the perceptions of physical activity among glaucoma patients in northern British Columbia. And I'd just like to start off by thanking my supervisor, Anne Sommerfeld, and my second reader, Dr. Peltier, for all their help throughout this project because I needed a lot of it. So here's just a brief outline of what we're going to go through. So I'll quickly run through the intro, methods, results, discussion of the thesis, and then finish off with some key kind of takeaway points from the research that I've done. So just a brief background on what exactly glaucoma is. So it's a progressive disease of the optic nerve, and it's associated with increased intraocular pressure most often. So what this means is that as the pressure of the fluid builds up within your eye, it compresses against the optic nerve, causing it to atrophy and leading to a reduction in peripheral vision. So it's associated with decreased quality of life and an increased risk of falls, and it is age-associated. So typically people with glaucoma are older adults. And so how is physical activity related to this? Well, physical activity has the potential to both objectively and subjectively counter the negative effects of glaucoma on patients. So that's seen through decreased intraocular pressure, improved quality of life, and reduced risk of falls. However, not all physical activity is beneficial.
So usually in the literature, the benefits of physical activity for glaucoma patients are seen in things like aerobic exercise. However, if you're doing something like yoga or scuba diving where you're having an inversion of the head, it's typically not beneficial because in doing that movement, you're increasing your intraocular pressure. So in light of this, I was surprised to find that there are no standard guidelines or recommendations for physical activity in patients with glaucoma. And this is something I found repeated throughout the literature and kind of led me to ask my research question, which is how do patients with glaucoma view physical activity in relation to their disease, both objectively and subjectively? So in order to form the basis for any kind of guidelines or patient-targeted educational materials, we have to understand where patients are at right now. So how do they perceive their disease in relation to physical activity and vice versa? So it was a qualitative study, and participants were recruited at their local optometry clinic at a small rural town in northern British Columbia. And the way this worked is that any patients who came in to the clinic with a previously established glaucoma diagnosis were invited by their optometrist to participate and fill out the survey. If they wanted to, then they did. If they didn't want to, then they didn't. Data was collected, as I mentioned before, in the form of a self-report survey. We included both closed and open-ended questions to kind of get a full perspective. So the two previously validated measures that I used were the question of habitual physical activity, which was, it's essentially a rating scale validated in older adults to kind of gauge where people are at with how much physical activity they're performing. And then the glaucoma activity limitation questionnaire 9, which was again a rating scale based on how difficult participants found certain activities that we would expect to be impaired in an individual suffering from glaucoma. So data analysis was performed in Microsoft Excel. We basically did descriptive statistics because we didn't have enough people to do anything with more statistical power, but it was still interesting to see what we found. So overall, there was a total of 9 participants. 7 of these were male. The mean age was about 76 years old. 4 participants reported ocular comorbidities, so in most cases this was cataracts. 7 participants reported previous ocular surgery, again, most frequently cataracts. 1 participant had a trabeculectomy of the left eye, which was a glaucoma-related surgery. And then the self-reported years since diagnosis ranged from about 1 to 30, which is something I'm going to come back to in a little bit. So in response to the GAL-9, so how difficult is physical activity, what you can see is the rating scale mean responses of the participants to those different measures on the rating scale. So as you can see, most participants reported little to no difficulty in performing these activities. And I should note as well that due to the influence of one participant specifically who had very advanced glaucoma and therefore reported severe difficulty in most of these measures, the means would be clustered more to the lower end if this participant was removed. So that's interesting to note. And then in response to the more open-ended questions, so what you see on letter A there is participant responses to the question of, do you feel that glaucoma impacts your physical activity performance? And as you can see, most people said no, which is very similar to what we saw on the rating scale responses that I showed you on the previous slide. Looking at letter B is the responses to the question of, would you be more active if you knew more about the relationship between glaucoma and physical activity? And again, you can see that most patients responded with no. And that's something that I found really interesting because you'd think that, or at least I thought that if I knew more about something, I would be more engaged to, translate that knowledge into behavioral change. However, that's not something that I found with my participants. And then looking at question C, it was the responses to, do you feel that physical activity impacts your eyes or your glaucoma diagnosis? So this was based on what I'd read in the literature. And as you can see again, most participants did not feel that that was a thing. So overall, the main theme that I kind of drew from the data that I had was that there's a very low patient disease-specific health literacy. So really, patients didn't really understand their diagnosis in general. They struggled to conceptualize the length of it. So when I asked that question, a lot of times people would tell me like when they got glasses, which is a lot different than when you're diagnosed with glaucoma. So that was something interesting. As I referenced on the previous slide, a lot didn't realize the relationship between glaucoma and physical activity. And then there was also confusion with other ocular morbidities. So again, when looking or asking questions about glaucoma, got a lot of answers about cataracts, got a lot of questions about a lot of answers about random surveys, or not it rings well. Random other diseases, visual acuity, glasses, things like that. So overall, that was the main theme. And health literacy wasn't really something that I was focused on when I conducted or created the project, I guess, but it is something that I definitely drew out of it. So research has shown that health literacy is linked with patient outcomes. So a lower level of health literacy is related to reduced patient outcomes. And then it's actually currently an area of focus for health promotion in glaucoma patients. Because glaucoma is an age-related disease, as the Canadian population ages, we expect the incidence of glaucoma to increase as well. So really investing in preventative, proactive health literacy programs for this population will decrease healthcare costs overall as the demographic changes, but it will also provide the best care for patients. So another study looking specifically at engaging older adults in healthcare and improving health literacy noted that capacity building is a key facilitator of healthcare engagement. So how the study worked was the authors basically cold called a bunch of older adults and were like, what would get you involved in your healthcare? And capacity building was one of the main themes. So this is really engaging people in their own healthcare, getting them involved, talking to their healthcare practitioners, and things like that. So when we combine health literacy with the focus of capacity building together, we have an effective strategy for glaucoma patient engagement. So it's important to note a few limitations that we had in this study. So first of all, it is a very small, limited sample size, which means that the data here are not generalizable to anywhere besides the small, limited sample size that I have. There's also a lack of objective ocular health measurements. So previous studies have shown that things like visual field is related to risk of falls. Because we didn't take visual field measurements for each participant, we can't say whether or not the amount of reduction in sight a participant had was related to their perceptions of physical activity. So that is a limitation. As well, the potential for the influence of confounders. So because we had such a small sample size, we couldn't eliminate individuals who had other ocular or systemic comorbidities. So patients with things like diabetes and COPD were still included in our data set. But it's important to note, especially with the ocular disease confounders, so for example cataracts, that those often co-occurred just due to the demographic in which the participants were. So moving forward, it would probably be better not to focus on one disease specifically, but to look at a patient's overall ocular health and ocular health care experience. Instead of trying to nitpick a little bit, to look at it as a whole would probably be a better focus for improving health literacy. So just a quick recap. Physical activity can be beneficial for glaucoma patients, but not always. Glaucoma patients generally have limited knowledge regarding physical activity in relation to their disease and regarding their disease in general. And so health literacy strategies should take a capacity building approach to help remedy this problem. So maybe this is like when you're creating an educational brochure about glaucoma, to include ways that you can be involved with other people with the disease, with your ocular healthcare provider. So really getting patients involved in healthcare with that patient-centered approach. So thank you for your time, and do you have any questions?
Questions from all? Oh, Luke.
Yeah, one of the last things you mentioned was that you had patients with a variety of conditions other than glaucoma, and I'm wondering if, based on your experience with the literature, there are known associations between glaucoma and some of those other conditions.
No, not that I'm aware of.
Okay.
Yeah.
Anyone else have a question? I will ask you a question. So what would intervention then look like? So combining the health literacy and capacity building, how would that look? What would that look like for physical activity if you were wanting to increase physical activity for people with glaucoma?
Okay. So one thing I will mention in relation to that question is that as I was doing the study, another study came out that said we don't know the physiology well enough behind ocular perfusion to make those physical activity recommendations. However, I think if I were in charge of designing a program, it would be either something online or some kind of like pamphlet where there's objective like facts about glaucoma, but also ways in which you can get active. So maybe that's something like connections with other people, as Kirsten mentioned, some of the key facilitators, things like that, including those along with the facts to kind of engage people
Okay, so next we have Anderw Shulz, and he's going to tell us about a project he's done in partnership with Sekani Family Services.
Yeah, so hello everybody. So my project that I've been working on for the last little while has been called Sekani Family Services Care Team Perspective on Diabetes Care and Management, a Quality Improvement Project. So this is a brief overview of what I'm going to be covering today. I'll let you have a brief look at it. It's fairly standard procedure, nothing surprising. So moving into the background and literature review, first I wanted to provide you a bit of context to the situation and what kind of established the foundation for this project. So as many of you know, northern BC regions show a higher prevalence and incidences of behavior-related conditions as well as chronic diseases, with a high proportion of these individuals identifying as Indigenous. Now, since 2010, Sekani Family Services has established and delivered their primary care model to their 11-member First Nations across north central British Columbia. And this is really to overcome some of those barriers to care in terms of managing and really targeting these behavior-related and chronic diseases. Now, an initial assessment of this program was conducted in the winter of 2016, and it was a very high-level approach to looking at this structure, from like the 30,000 feet view, looking at cultural competency, accessibility, ease of use, these types of concepts. But it really set a foundation on which other projects could be built, and that's really where this project came out of. So with my little bit of background in diabetes care and management among rural populations and their interest in diabetes care and really improving that, our objective was born. So this was really to inform the CSFS Diabetes Care Quality Improvement Initiative through the collection and analysis of interview data from CSFS care team members regarding their role in diabetes care in a specific Indigenous community served by the CSFS primary care model. Now, moving into how I did this. So basically, about a year and a half ago, in collaboration with my supervisor, Dr. Clausen-Ross, and Sekani, we started having some communication about what kind of objectives were for them, as well as kind of where I was looking at. And then this past fall, a topic was nailed down, and finally, I went into actually delivering the project. So in the early winter of this past year, I went out to the community and started talking to them and saying, okay, well, this is kind of my idea, this is where I'm at, would you be interested in participating? And the uptake was 100%. All the staff at the healthcare center, all 8 that I could interview, were totally on board and jumped onto the project. So I did recruitment through that communication as well as an email that was sent out. And then participants completed an 11-question open-ended interview with myself. We did participant consent at the beginning of the interviews. And these interviews were conducted either in the health facility in which they were working or over the phone at the participant's convenience. Now, hemorrhagic phenomenology was used as a theoretical approach for this project, as it really allowed to pull out some of those really more specific factors that traditional research might overlook, because we were really trying to gather the provider's perspective on diabetes care and management and what was really going on in the real world. So getting into my themes identified, as I went through the data and coded it, it was interesting because I pulled out 3 core themes as well as 8 sub-themes. Now, the core themes were accessibility, communication and collaboration, and reciprocal determinism in relation to patient acceptance and adherence. Now, to dive into these a bit further, accessibility, the 2 sub-themes within this were accessibility to healthcare services and quality affordable food. So to describe healthcare services, this was a really interesting topic because it brought forward some of those key attributes that a lot of healthcare services in delivery in northern BC and really most rural and remote areas face, primarily around access to allied health professionals. Now, it's interesting that even though this was an issue brought up by multiple interviewees, one of them in particular, the registered nurse, had described how they do have access in this community to a northern health dietitian, but it's only once every couple of weeks. So meeting the needs of this population was simply not happening because of that. And then there was also mention of other allied health professionals being integrated in. Now, interestingly, there have been some creative solutions, I guess, to really bridging the gap between care provided in the clinic and as well the education that was talked about or that's happening at home in a lot of the patients' cases. And it was interesting because the physician described how he uses mobile communication, texting, phone calls, email, at any time with the patients to really deliver that continuity of care that these patients need. So the patients in the community, he actually gives out his personal cell phone number, says, give me a call whenever you need it. And they do, and they really use this system as a way of bridging the gap and really creating that care that these patients need. Now, in terms of accessibility to quality, affordable food, this is again a chronic issue across many rural and remote areas. And really at the end of the day, it came down to the affordability of food. So it was interesting, one of the participants, the community health representative, had described that for a lot of individuals living on a limited income, affording something like a head of lettuce is just too much. And I remember her saying, you know, a head of lettuce is $3, but $3 is a lot when you don't have any money. So this is just something to really consider when we're working with these populations. And interestingly, they've had some creative solutions come forward, such as the implementation of a community garden in this community specifically. Now, this community garden has been widely, supported and very openly accepted by the community, and they're very happy that this is available, but again has run into some of those barriers when kind of looking at longevity of the programming and really extending services into the later fall and even early winter months. So what they have proposed is implementing a cool room or some storage facility to basically prolong that harvest. Now, in terms of communication and collaboration, some other interesting kind of approaches came out of this. But the biggest thing was really between the provider to provider and the management to provider levels. And this was really looking at team-based care. Now, one of the biggest attributes of this primary care model that CSFS is delivering is team-based care and this interdisciplinary integration of a variety of health professionals, including those allied health professionals, as I previously mentioned. But interestingly, in multiple of the interviews that I conducted, was that it was brought forward that though we're saying we're working as a team, and everything, on the surface looks like we're working as a team, on the really deep level, we're not working as effectively as we could as a team. So this is just something to consider moving forward, and really looking at how we can integrate those services together to provide that continuity of care. Now finally, reciprocal determinism in relation to patient acceptance and adherence. Now, reciprocal determinism is a theory described by Bandura, and basically it describes how these three factors, personal, environmental, and behavioral, both influence a behavior, as well as how the behavior influences these three factors. Now, interestingly, these 3 points all had some attributes that were quite familiar among this population of interest. So personal factors included primarily literacy level. Now, this was interesting because it was described by the registered nurse that even the Canadian Diabetes Association offers a plethora of wonderful resources on diabetes care and management, but it's just too wordy and it's not at the literacy level of the community members. So therefore, some creative solutions around using pictures as a way to describe things, as well as even using blister packs for medications, were some ways to overcome some of these barriers. Environmental factors primarily included intergenerational trauma. Now, this was an interesting attribute because it was described by a social worker, because we have at the very foundation things such as poor quality housing, food insecurity, low socioeconomic status, unemployment. Then to pile on top, we have intergenerational trauma. Then on top of that, we have diabetes care and management. So ultimately, when we have these compounding factors, diabetes care and management falls very low on the priority scale for these individuals, and therefore, it's not being effectively managed, further perpetuating the cycle of despair for these individuals. So when we look at this, we have to really consider this more holistic view of how we view patient care and looking at the broader aspects that might be influencing it. And finally, the behavioral factors. Now, this was primarily around self-efficacy. And it was interesting that, the physician had really talked about this and summed it up quite nicely, but it was mentioned by many patients. Simply the burden of disease, of diabetes, having to check your blood sugars regularly, having to do your medications and all this stuff, is just a huge burden for a lot of these individuals. And therefore, considering that in terms of self-efficacy and drive to actually, manage conditions effectively, is just something really important. Now, like I said, when we're looking at this, I feel like we have to take a more holistic approach. And this quote was actually presented by a social worker, somebody outside of the traditional realm of biomedical service providers that typically engage in diabetes care and management. But he summed it up really nice, and I'll just read this for you. So I'm a mental health worker, and the name of our program is Mental Health and Wellness. And so we want to put the focus on a person's well-being in general. A more holistic approach, the mental, physical, emotional, spiritual. Kind of like the medicine wheel. Diabetes kind of fits into an overall well-being, not just one. So this just really describes this in a more holistic way. And really, as I transition into my conclusion here, I broke these themes down and described them into these sub-themes and core themes. But really, these things are complexly interrelated. And we cannot discredit that, and we cannot ignore that in this project. And that was one of the biggest things that was brought forward in this. As well, humoric phenomenology really helped to facilitate that and pull out some of those more community-specific and just really personal factors that these individuals were describing. And because this project took a quality improvement approach, it can really inform and guide future quality improvement initiatives as well as community-based initiatives. And not only that, but it can also legitimize them because it's going to be found or rooted and with a solid foundation of literature and data to really support such changes being made. Now in doing this, I've provided some recommendations, which I have described a little bit earlier, but I'll just go through them again to really highlight some of these moving forward. So firstly, coordinating the integration of allied health professionals. Now, as I mentioned, Northern Health is a partner in delivering care in this specific community, but also, collaborating with them more moving forward, as well as integrating the First Nations Health Authority on a deeper level, and even potentially the Provincial Health Services Authority. We can also look at establishing regular patient care meetings and collaborating with supervisors to integrate the care and really see what the community level individuals are doing to deliver the care to the patients. We can improve capacity through supporting community-based initiatives, such as the implementation of a cool room or storage facility, something like that, as well as further supporting, the community garden initiative and these types of things. And we can also establish creative solutions for improving access to quality, affordable foods, such as community buying programs or even transportation to and from like stores in that larger centers. And finally, we can deliver more upstream preventative programming and better support patients both prior to, during, and after their diagnosis. Now, interestingly, one of the attributes that came up multiple times in the interviews was the integration of a mobile diabetes team, which Sekani offers. But again, this team is based out of Prince George, and to serve 11-member First Nations and travel out to these communities is a huge burden on them, and they just don't have the capacity to, go out to these communities on a more regular basis. So therefore, either developing more of these teams or integrating this team better into the care services that are being provided would be of great benefit. So I'd like to thank the participants for taking the time to engage with me on this project and really share some of those perspectives that they've learned over their many years of service. I'd like to thank Keahey Family Services for this collaborative and learning opportunity that I've had the opportunity to engage in and learn so much from, and the project supervisors for their guidance and support during this project. So thank you very much. These are my references. And I'll take any questions.
Questions for Andrew?
I have a question. You mentioned that the physician provided patients with personal cell phone number.
Yeah.
Do you know, do they have secure text messaging?
Yeah.
Yes.
Yes.
Okay.
So it's all
Yeah,
all
I'm
above,
just curious.
no, it's all
Just
above board, but
Yeah.
it's just he carries a cell phone with him. That's what I should have said, I guess. But he carries a cell phone with him that he just basically accesses them anytime. It was incredible. Like I was floored.
Yeah, it's really quite a powerful service when you can use it. Can I ask another question?
Yeah.
The interdisciplinary team, so I'm assuming that they're not all co-located together?
Yeah, so it's interesting to see that a lot of these individuals that are based out of this center also serve other centers. So, and then like Sekani, because they have, because it's there was basically eight members to this health facility, and that includes people like the medical office assistant, community health representative, these types of individuals. But for instance, I interviewed a family preservation worker, somebody way out of the diabetes care team, but quite integrated, interestingly enough. But anyway, she was co-located in multiple locations and travels in, so, yeah.
Did Sekani have some ideas of how they would start facilitating that interprofessional team development?
Well, at this point, this is why I'm presenting it to them at this point. But again, it comes back to just building that team together more. And I haven't presented this to them yet, but hopefully
Throw in
it's
the
coming.
national framework for interprofessional competencies.
Yeah, thanks.
Oh, Trina, yeah.
Hey, great presentation.
Thank you.
I'm just curious how, because you framed it as a quality improvement project, so how did you decide to do that as opposed to calling it a traditional research project?
Yeah, so that was an interesting dynamic. It started as a research project, but then transitioned into a quality improvement. And just given the context of Sekani and what they were trying to achieve in kind of collaborating on this, it was just a way better fit for their services. And because they had this quality improvement initiative already based in diabetes care and management, it was just a better fit for their capacity as well as mine, given the time frame for the project. So, yeah. Great learning opportunity, I'll tell you that.
Thank you, Andrew.
Thank you.
So we're at the halfway mark. If anyone needs like a quick stand break or anything, please go for it. We can give you like a couple minutes while we switch.
We have a training program in order to help to facilitate. It's Gyapay. If you don't want to say it,
No, I just don't think you're wrong.
it's Gyapay. Yeah, it's so it, yeah.
You never know.
I can pronounce it. It's not which language. It's Hungarian, so we have different alphabet.
Oh, okay.
So like the G and the Y's are actually hard.
Gyapay.
It's like Gyapay. Yeah, yeah. It's tricky.
No, it's okay. I just don't like.
I know, and it's fine because I'm so used to it. It's like, yeah, it's okay.
People's names right. I just downloaded it as a PDF. Your thing. So I submitted it.
Okay, well, yeah.
No, wait, that is a PDF. It's a PowerPoint. So you should.
Oh, perfect. Oh,
Yeah. So there you go.
yeah, the formatting.
Yeah, that's fine.
Oh, perfect. Okay.
Yeah.
Yeah, no, for sure.
We got time.
I know, right? I feel like when you do it, it's almost like anticlimactic.
That's like, oh, okay.
We're done. I know, right? When are you using the chat?
I recommend the top university.
No, he can't make it.
Oh, can't make it. Sorry. No, it's for here.
I think he's in Vancouver for meetings or something, so I told him that he could watch the,
Video, hopefully.
if it's online afterward.
Yeah.
So close.
Yeah.
Okay. Oh, good. Good. I get to do
There's like this new, if you have Spotify station.
I did have it.
So you Google it,
I will read it.
if you have a family plan, it's telling you.
Yeah.
Have it after
Yeah.
class.
Edited first. Okay, because I love it. Okay, well, all right. All right. Well, even with yours, we had comments and stuff. Yeah. Oh, good. Oh. Nice smell. The pineapple. All right. I want one of those cinnamon things that I saw some. Are they cinnamon look?
Yeah.
Yep.
Oh, this one's white.
Oh, I'll leave the names.
Don't know what to tell you.
Or
Mine
maybe,
has some.
maybe some of them are like more cheese. Yeah, that does look good.
Not like a cupcake at all.
To be honest, that's what they are. They're just cupcakes. Oh, yeah, big piece of it.
No, it's a muffin.
It's a muffin, it's a breakfast food.
It is a breakfast food.
You can have chocolate for breakfast, I allow it.
This time of your chocolate is good.
You and my mother disagree on that. We were never allowed to have Cocoa Puffs when I was growing up.
Oh, yeah, probably.
No, they were disgusting.
They were just
Or Count
Count Chocula. Count Chocula.
Because that's all easy and choice.
going to.
Yes.
Hey,
MSc?
what in your ideal?
Well, yes.
Yeah.
Both the schools of public health, so it's,
Oh, yeah.
and it's not, so it is an MSc, but
Yes.
it's within the School of Health Sciences.
Okay.
Really? Did you try?
Yeah, and there's like a literature specialization.
Yeah, but it's a thesis.
No,
It
I
is,
mean,
so it's an MSc.
it just seems a shame.
All right, I think we'll keep moving so we can get done on time, although we're doing pretty well so far. So next we have Julia, who's going to present her project, it's a long title, on climate change and health in resource-dependent communities.
So hi everyone, thank you. So my name is Gyapay, and I conducted my honors thesis under the supervision of Dr. Margot Parks and Dr. Chris Busey. So my long title is Climate Change and Health in Resource-Dependent Communities, Exploring Frameworks and Perspectives for Northern British Columbia. So today I'll be providing a really brief background on the overview of climate change, health, and resource-dependent communities, explaining what the gap is within this field of research, and then describing what I did and what I found and some of these implications. So we know that climate change has simultaneously been called the greatest threat and the greatest opportunity for public health this century. There's also a current need for a more integrated understanding of the impacts of climate change and resource development specific to regional systems. And furthermore, little is known about these interconnections between climate change and health in resource-dependent communities, particularly in northern BC, where these communities are more likely to be resource-dependent. So there's a critical gap in this research addressing this interface between climate change, health, and resource development, like I mentioned, particularly in resource-dependent communities in northern BC. So many of which are further characterized as rural, remote, and Indigenous. And so there's a gap that was, so this gap was identified by two national projects who I collaborated with, the ECHO Network and then the Climate Change Communication and Engagement in Canada's Provincial North, or which I'll refer to as the CCCE project, which I'll explain a bit more in further detail. So ultimately, my primary research objective was to determine what insights can be gained about climate change and health in northern BC resource-dependent communities to be able to inform conceptual and practical action. So the objective of the first phase of my qualitative research was to identify qualitative, descriptive, conceptual frameworks that address climate change and health in ways that are relevant to northern BC. And so my research question sought to determine what existing climate change and health frameworks can be applied to northern BC resource-dependent communities. And note that conceptual frameworks provide a systematic approach to organize concepts, ideas, and notions of a subject meaningfully, and they can be depicted either visually or in written format. So to answer this question, I first conducted a preliminary scoping phase so that I could situate myself within this climate change and health literature. And so I wished to understand how were and how are people understanding these relationships between climate change and health, and how do they relate to resource-dependent communities in northern BC. And so then I conducted a literature review of these frameworks in the peer-reviewed and gray literature, and I coded this collection of frameworks into key categories and then created an annotated bibliography. And so drawing on this knowledge gained from the inductive scoping phase, I designed a targeted systematic review to be able to answer the following question. So what existing climate change and health frameworks published in peer-reviewed journal articles, specifically between 2013 to 2018, can be applied to resource-dependent communities in northern BC? And you might be wondering, well, why did I choose this time frame? And this was because I wanted to understand the relationships between climate change and human health that are currently being depicted in the literature, but to have a large enough time frame to account for two influential agendas for climate action that were signed in 2015. And this was the Paris Agreement and the United Nations 2030 Agenda for Sustainable Development. So my targeted systematic review combined the methodologies of a scoping review and a systematic review, in that I wanted to identify some of these gaps and key themes in this research, similar to a scoping review, but I had a highly focused research question and predefined inclusion and exclusion criteria, similar to a systematic review. So following this completion of the targeted systematic review, I collected a total of 92 articles, and after my screening, I ended up with 11. And these were all depicting, like I mentioned, these climate change and health frameworks. So I synthesized the findings into key categories from these collection of frameworks that could be applied to resource-dependent communities in northern BC, which are presented in my own framework shown here. And so these key categories that were particularly relevant included the state, as shown here, which I subdivided into social and ecological states. And within social states, I further broke this down into living conditions, the social environment, economic and work environment, and service environment, as well as looking at social and economic inequalities and health status and behaviors. And then within exposures, I further broke this down into direct and indirect exposures based on my findings from these frameworks. And these included examples such as direct exposures, like exposure to heat waves, wildfires, these types of examples. And then indirect exposures, which included things ranging from vector-borne illnesses and diseases all the way to poor air quality and water quality. And then effects were ranged everything from urban heat effects to migration and conflict. So that was quite a wide range of effects that I found. But you might be wondering, well, what didn't fit for the northern BC context? So I found that many of these examples describing the exposures and the effects on health were not applicable to a northern BC resource-dependent context, since these frameworks tended to focus on context in Africa, Asia, the United States, and Australia. So overall, I found that there was a lack of engagement with local and regional contexts within my set of frameworks, since they were addressing the impacts of climate change on a global or a national scale. And also I noted that there was a lack of acknowledgement of resource-dependent in northern, rural, remote, and Indigenous contexts. So overall, I found that this collection of frameworks was not well adjusted to capture the key realities in northern BC resource-dependent communities. So the second half of my research aimed to deepen and inform the understanding of these relevances, strengths, and weaknesses of my identified frameworks by asking, how does the current literature on climate change and health frameworks relate to the lived experience of climate change in these northern BC resource-dependent communities? And so to do so, I obtained pre-collected interview data from the CCCE project, which is led by Dr. Lindsay Galway at Lakehead University. And so these interviews sought to address public beliefs, attitudes, and perceptions of climate change and climate change action in their two case studies, which one was in Northern Ontario, in Thunder Bay, and one in Northern BC, here in Prince George. So within the Northern BC case, the interviews were conducted by members of the CCCE team with key informants, and this included individuals such as climate change activists, researchers, decision makers, and government representatives, and they were conducted in 6 communities between April and August of 2018. So I coded and analyzed these 11 semi-structured interviews from Northern BC using thematic content analysis. And following my analysis, I created my own refined framework depicting these climate change pathways to health outcomes specific to these northern BC resource-dependent communities based on my collective findings gathered from my targeted systematic review and analysis of the interview data. So I found that the interviews emphasized the importance of attending to living conditions, particularly political and economic environment, social and health inequities, Indigenous health, and how to be able to promote climate action in northern BC. So for example, these interviews were depicting tensions between economic and environmental health in northern BC, which is largely influenced by politics and local resource-dependent economies, demonstrating these complexities of how to address climate change and health. So a participant explained these tensions by saying, it shows how clearly that the debate about environment versus economy has been stuck with some people. They truly believe it's just the way it is and we can't have both. I do think it's still the main one that really pushes people to take one camp or the other. And that's why, again, full circle, it comes back to politics. And so addressing this idea of, well, how can we do it all? A participant mentioned, how can you save money, keep your job, build resilience, and give for yourself and give your kids a chance? So based on the insights gained from my interviews, I refined my original framework for the targeted systematic review and came up with this modified framework. So in blue is the key themes and categories that were informed by these conversations from the interviews. And so my framework highlights the importance of contextualizing climate change pathways to health outcomes, so as depicted here, situating ourselves within resource-dependent communities in northern British Columbia, specific to rural, remote, and Indigenous populations. And most importantly, the social and ecological states are complex within northern BC and reflect unique political and economic contexts, particularly within the context of resource dependence. So in terms of knowledge mobilization, I plan to engage in knowledge exchange conversations with the two national projects that I collaborated with to receive some feedback on my proposed framework. And some next steps that are needed within this field of research are the contextualization of global climate change and health frameworks at the local level to be able to drive future actions. So finally, there's a need for collaborative, transdisciplinary climate change and health action in northern BC that attends to local political, social, economic, and cultural contexts in the goal of reducing community vulnerability to the health impacts of climate change. But interestingly, the best methods on how to do so still remains unknown, and this is the next step that's needed within this field of research. The contribution of my refined framework includes the facilitation of the communication of these complex interrelationships between climate change and health, specific to resource-dependent communities in northern BC. And so this framework promotes the reconnection between the social and ecological determinants of health, as well as these co-benefits for climate action for both environmental and health sectors. And on a broader scale, in the face of recent extreme climatic events in northern BC, climate change promotes an incentive to be able to implement actions that promote health. And such transdisciplinary action has the potential to increase the adaptive capacity and resilience of communities. So thank you. Are there any questions?
Go ahead.
When you were describing the original approach for your scoping-like systematic review, you mentioned both peer-reviewed and gray literature. I'm wondering, did you end up looking at any gray literature, and did it make it through your cutoff to your 11 final articles, and what were those like?
Yeah, so interesting. This is where the confusion comes up about. So really the methods focused, the bulk of it was really addressing the targeted systematic review and the interview data. So although I spent a lot of time on what I called this exploratory scoping phase, that really wasn't, that was really just to inform myself, so that I could have a historically accurate sense of what are these conversations like. So really that's an interesting question, because I had a lot of discussions about this of, well, okay, how can I describe my methods and what I did, because really the focus was on this targeted systematic review, which was the second and third steps.
Right.
So yes, so for that phase, if we can call it that, that was a literature review, just generally, so it was inductive. I just really wanted to learn what's out there.
Right.
Within the last 30 years or so, how have people been thinking about these topics? And it was also so that I could see if there was progression within this field of research, so that when I was doing the targeted systematic review and I found this really synthesized collection of 11 articles, I wanted to be able to compare those so that I had that idea of what those conversations were like. So it was, yeah, it was more just largely inductive, so that I could find out what was out there.
Okay, thanks.
Anyone else have questions? Are there any online questions?
I'm just checking, I'm not done right now.
Okay, thank you, Julia. Okay, next we have Kevala, who's going to tell us her project about moderate exercise and the effects on cognition.
Yeah, so thanks for the introduction. As Chelsea said, I'm Kevala, and today I'll be talking about my honors project that was supervised by Dr. Tammy Clausen-Ross and Dr. Luke Harris, and it's entitled An Investigation of Acute Moderate Exercise's Effects on Cognition. So to summarize that long title, I want to see what happens after exercise to cognition and cerebral oxygenation. So first, some background on exercise and cognition. So exercise has been shown to increase cognitive ability during exercise. We've also done some research into the neural correlates of what changes in the brain to increase that cognition. And we found that increased cerebral oxygenation has been shown to increase cognitive ability during exercise. So I found that I was really interested in the topic. So last year, I did a separate study that looked into the surface level of this. So what I did was I did a cognitive test, a 10-minute exercise period, and then a post-cognitive test. So this is an output showing cerebral oxygenation from NIRS, and I'll talk about NIRS in a bit. But in the red box here, you can see that there's a slight increase in cerebral oxygenation. And then in the post-test, in the blue box, you can see that the cerebral oxygenation remains elevated. So what happens after exercise? Does cerebral oxygenation stay elevated for 10, 15 minutes? What about an hour? So I did more research into this and found that we really don't know. There's very few studies on this, both with cognition and with cerebral oxygenation. So that's what my study wanted to find out. The purpose of my project was to see how cognition is affected after exercise. I also wanted to see if exercise impacts hemodynamic values, such as cerebral oxygenation, during and for an hour after exercise. So to measure cognition, I decided to use executive function. So there's 3 different components to executive function: inhibition, working memory, and mental flexibility. So I decided to use 3 different cognitive tasks to measure each of these individually. The go, no-go task measured inhibition, the reading span task measured working memory, and task switching measured mental flexibility. All of these executive functions utilize the prefrontal cortex, which is something that I could measure cerebral oxygenation in with NIRS. So what's NIRS? It's near-infrared spectroscopy. It's non-invasive and it's easy to use. This is the machine right here, and the optodes that shine near-infrared light are attached to those blocks right here. So what it does is it uses near-infrared light to measure cerebral oxygenation in the brain. Specifically, I measured through the prefrontal cortex, which I said that my executive function tasks will utilize. So how did I do this? My testing sessions were 3 hours long, so thank you to those participants for sticking around. So we started with a baseline measurements, which were the 3 different cognitive tasks, a glucose sample, and then a baseline NIRS. The baseline NIRS, the participants just sat in a chair and looked at the computer screen for 5 minutes. Then, if they were in the exercise group, they did 20 minutes of aerobic exercise at 60% of their heart rate reserve. If they were in the control group, they sat back in the chair and listened to a statistics recording for 20 minutes. Then, as soon as the 20 minutes exercise or statistics recording was done, we started the post-exercise section of the project. So here, at 0 minutes post-exercise, we did the 3 different cognitive tests and a glucose sample. Then, every 15 minutes after exercise, we did another round of cognitive tests and then another glucose sample at 60 minutes. So, what did I find? Since I have limited time today, I'll only be talking about 3 things. 1, I'll be talking about the total hemoglobin in the different cognitive tasks that I did. I'll also talk about how I found that NIRS changes are task-specific, and I'll also briefly mention my behavioral data, which is my cognitive tasks. So, here are some nice graphs describing my oxygenation data for total hemoglobin. So here, all of these are in the right prefrontal cortex describing the total hemoglobin. And total hemoglobin corresponds to blood volume in the brain. So in the first graph we have here, you can see that we have statistical significance at 0 minutes post-exercise and 15 minutes post-exercise. So this was measuring the go-no-go task for inhibition. So this suggests that the brain responds differently while doing those inhibition tasks for up to 15 minutes after exercise. Now you can see at 30 minutes, it's also elevated, and even at 60 minutes, it's still elevated above the control group. So here I saw that it wasn't statistically different, but you can still see that there is a difference, even up to 60 minutes post-exercise. Now, in task switching, which measured mental flexibility, I saw a similar trend. So at 0 minutes post-exercise, there was a statistical significance, as well as 15 minutes post-exercise. Then at 30 minutes, I saw more of a drop towards the control group, but then again a slight elevation at the end, and the control group and the exercise group still don't meet at 60 minutes post-exercise. Then finally, I have my reading span test, which measured working memory. So here I saw something different, where I saw a statistical significance at 0 minutes post-exercise, and then a pretty steady decrease. And at about 30 to 45 minutes, the exercise group was the same as the control group, suggesting that working memory declines, or total hemoglobin response to working memory declines steadily after that exercise period. So what can we take away from these three graphs? So it looks like in inhibition and mental flexibility, total hemoglobin in the brain responds similarly when doing these two cognitive tasks after exercise. Then working memory, we see something a little bit different, where the effects are more pronounced at the very beginning after exercise and then decline. So another thing I want to talk about is that my total hemoglobin changes appear to be task dependent. So in my procedure, I did the cognitive tests, and then the participants would sit still for 15 minutes and do the next round of cognitive tests. So during these sit still periods, which you can see right here, I didn't see any statistical significance. So why is that interesting? So I did find, as you saw on my last slide, statistical significance in my cognitive tests. So this appears that total hemoglobin in the brain reacts differently when you're actually doing the cognitive tests after exercise, rather than just sitting still and not doing anything. So before this, we thought that the changes after exercise would be a global shift in hemodynamics, but it appears that it's task-specific. So the control group and exercise group were relatively the same while sitting and not doing anything compared to the cognitive tasks. So, did this mean anything for my behavioral data in my cognitive tasks? So, I didn't see a change in my cognitive tasks at any point, but this doesn't mean that there's no effect. When I was looking at my data, all of my cognitive tasks in every single situation, exercise appears to be slightly better than the control group. But since I had such a small sample size of 15 people in each group, I don't think that there is no effect in the data. I think that if I had more participants, I'd be able to tease that out. And these are also just my preliminary results, and I plan on doing more analyses after this as well. So, why is this research important? So first, this is new research in post-exercise, both dealing with cognition and NIRS. For my literature search, I found maybe 4 papers that focused on this, and they either did NIRS or they did cognition, and no one records NIRS for an hour after exercise. So that's new research to add to the literature. Also, I'm hoping that this project can have future implications in the real world for people with dementia. So, executive functions have been shown to decline during dementia, and exercise has also been shown to improve cognition in people with dementia. So all of this research has come for the during exercise portion, and no one studied that after. So if those cerebral changes that I found in my study do have an implication to cognition, people with dementia could potentially do exercise and then go do those cognitively draining tasks afterwards and improve their quality of life. So my main takeaways from this project are blood volume is impacted by exercise, and these factors seem to last about 0 to 15 minutes after exercise, statistically significantly anyway. And it also appears that hemodynamic changes are specific rather than global, which is also interesting. So I'd just like to say a very special thanks to a whole bunch of people who helped me with this project, because I needed a lot of help. So my two supervisors, Dr. Tammy Clausen-Ross and Dr. Luke Harris, and then everyone else who helped me. Also, I had these amazing lab assistants who gave up 3 hours of their week to come and sit in the lab with me for a whole month. And also my participants who were willing to stay in a 3-hour lab experiment and exercise for 20 minutes for me. These are my references. And any questions?
Questions? I knew you were ready for it. We'll come to you next. Go ahead.
Okay. So are you really telling us that statistics is less stimulating than exercise?
Yes. We decided to use a statistics recording because it's been shown that that's like the minimal like baseline level that your brain goes to when you're listening to statistics. So I thought that was pretty fun too.
So here's the real question. So you did say that even though you didn't see any statistically significant behavioral effects, it doesn't mean that there is no effect.
Yeah.
So can you give us a brief summary of some things that might help you in the future to actually see that effect?
Yeah, so since my sample size was only 15 in each group, that greatly limited or decreased my power. So since my power was so low, it was hard to get those significances out of my data. So I did that like G power test, and I need at least like 50 participants each group. So that would be at least a year of testing. But yeah.
Can I ask about 3 questions?
Yeah.
First one, how old were your participants?
We had 18 to 25, I believe.
Okay. Why did you use right frontal instead of left?
So I did measure from the right and left, but today I just talked about the right. In the right prefrontal cortex, that seems to be where I saw my most like changes. Now this could be either because it was more, the cognitive tasks were using that right frontal cortex more, or that exercise affects it more. We don't know. I did some research into like which cognitive tasks are supposed to be like task dependent to the right and left, but in some of the textbooks I found like, yes, working memory is the left prefrontal cortex, but in reality it's not that simple. And they like both use both of them. So.
One last one. Are there any implications of a practice effect doing the same test multiple times over an hour?
Yes, that's a fantastic question. So that was something that I really had to take into account. So for my literature review, I did a huge search on trying to find tasks that don't show practice effects. So I did see practice effects in my, which ones were they? The go, no go, and the reading span. So I did see them in my task switching, which I thought was interesting. So that could have been something that could have also like flattened out my behavioral data. And since we were doing like 7 cognitive tests in 3 hours, the practice effects were something that definitely is an issue. And in the future, we can try different cognitive tests that don't have practice effects, but it really is like a trial and error thing of trying to see which ones don't and which ones do.
Oh, Trina, go ahead.
I just have this is a naive question, and you might have already said it, but what kind of activity did they do? What kind of physical? And is it dependent on the type of physical activity?
Yeah, for sure. So my participants did 60% of their heart rate reserve, which is their maximum heart rate minus their resting heart rate, and then times 60%. And so that's about a moderate exercise level. What the literature shows is that the more you exercise or at the higher intensity, the more cerebral oxygenation occurs in your brain, except if you reach your like maximal point where you surpass your VO2, then the cerebral oxygenation sharply decreases. So I chose moderate exercise between 60% or at 60% because it's been shown to be the best for increasing that cerebral oxygenation, which my theory was that the cerebral oxygenation would impact cognition, as other studies have found that. So that's why I chose that.
Okay, thank you very much.
Okay, thank you.
who will wrap up our seminar with her presentation on a text message intervention on the student.
Hello everyone. Now that I'm standing up and you are all sitting down, I'm going to talk about sedentary behavior. So I did my project on the seemingly impossible task of changing students' behavior, specifically sedentary behavior. So just briefly what I'm going to talk about, the purpose of why I did this study, why on earth am I doing this, the methods that I used, and some of the results that came out of those, and then draw some conclusions from those results. So as some past presentations alluded to, Northern BC has a very distinct context compared to the Lower Mainland. We experience very high rates of chronic disease compared to the Lower Mainland and require very context-specific prevention strategies due to this. And these are due to the unique barriers and facilitators in the environment, such as weather, infrastructure, and geography. And these all hugely impact health-related behavior, specifically physical activity and sedentary behavior. So I'm going to pose a question. It's only 11 o'clock in the morning. How long have you been sitting today so far? So I can think I got up, sat down for breakfast, sat down in my car to drive to school, sat down in a sweat, nervous for this presentation. And so it's such a passive behavior, but it accumulates very, very quickly and we don't really realize it, compared to exercising, which is a very active behavior and we can very clearly quantify it. And so what is sedentary behavior? Very briefly, it's any waking behavior below 1.5 MET, metabolic equivalent. So just how much activity is going on in your body. And so all of you right now are about at 1 MET. I am above. And so I am taking a non-sedentary break because I am above that 1.5 MET. And so why am I talking about sedentary behavior? So sedentary behavior is associated with an increased risk of all-cause mortality and morbidity, as well as increased risk of depression and other mental illnesses, and decreased self-esteem and prosocial behavior. And this is all independent of leisure physical activity and other health-related behaviors. So you might be guessing that university students are very sedentary, and I'm sure some of the faculty in the audience can attest that they are very sedentary as well. Absolutely. So the general population averages about 6 to 8 hours per day, whereas university students are at 10 to 12 based on accelerometry data. And although the literature says that university students can actually meet those physical activity guidelines of 150 minutes per week, that still leaves a whopping 9,910 minutes in that week to be sedentary. So that ratio can be very, very skewed. And a study done by Ekman et al. With over 1 million participants found that people averaging over 8 hours of sedentary behavior per day need approximately 60 to 75 minutes of moderate intensity physical activity per day. So that's a lot of activity with busy schedules for university students. So there are ways to mitigate it, just decrease those hours of sedentary behavior, or break it up into shorter bouts of 20 to 30 minutes, which is recommended. So am I going to change this behavior? Who has looked at their phone today? Show of hands. Great. So, knowing the demographic that I wanted to target with an intervention, as well as past literature that has proven that text message-based interventions are effective for changing a wide variety of health-related behaviors, I thought that this would be, firstly, an inexpensive and feasible intervention, as well as an effective one for this demographic. And so, my project will investigate whether a text message-based intervention tailored for university students will decrease the total hours of sedentary behavior, as well as increase the frequency of those non-sedentary breaks. And through grounding it in theory and based on past literature, we hope to see those changes. And so just briefly going over this theory that I chose that has been used for sedentary behavior in previous studies. So it's bridging the intention to decrease sedentary behavior, because we all have the intention of doing it, but actually moving it into action. So that first phase has a few things that build up that intention. So that includes outcome expectancies and risk awareness, as well as self-efficacy along the whole process. And then when you want to move that intention actually into action, there's some planning that goes into it, as well as coping with barriers. And so, how I used it. So, I created 4 types of text messages. There's going to be tips. So these are tailoring to that context I was talking about at the beginning of my presentation, as well as helping in the planning of when you're going to decrease those sedentary hours. There's challenges. So these are goal-setting prompts and also assist in the planning stage. There are facts. These target those outcome expectancies and risk awareness. And then reminders, so helping just overcome that barrier of forgetting to stand up. And so these 4 texts, each participant received 1 per week. So they received a total of 4 texts during the week, between the hours of 9 and 4 p.m. And so here is a timeline of my study. So I had 3 time points in which I sent out a survey at the baseline, and then post-survey, and then a 2-week follow-up. And the whole intervention lasted a total of 6 weeks. And then the measures that my survey was measuring, of course I measured sedentary behavior, but I also measured physical activity levels, as well as self-efficacy and constructs from that HAPA model. And I also included a really important intervention evaluation, which just gave the opportunity for participants to give feedback on how they thought the intervention was. All right, so what came out of this? I recruited 161 to begin with, and then 99 people responded to that baseline survey, 85 at the post-survey, and then 72 at follow-up. So that's a pretty good retention rate of 72%. That just speaks to how engaged the students were in my intervention, possibly that they liked being involved, and I also had incentives to filling out each survey. And so some participant characteristics. So my mean age was 19. My demographic that I was targeting was ages 17 to 25. So that's right in the middle there. And my sample was skewed to first-year participation as well as females. This is to be expected. The first-year population is significantly larger than other years. As well, it was skewed to those in health science-related programs. And then, interestingly, at baseline, 1/3 of individuals were meeting physical activity guidelines. This is higher than the adult population that averages about 15% meeting those guidelines. And my intervention evaluation, so what came out of that? So participants thought the frequency and the length of text was good, but then a little bit lower, only 58% read and understood half or more of the text. So this may allude to that maybe the content wasn't interesting or it was confusing to understand, so that's an important point to reflect on. 63.5% liked receiving the text, and then 58.8% perceived a change in behavior because of the intervention. So, did behavior change? Stay tuned. So participants were asked which text they preferred. Most of them said facts, interestingly. And then a small proportion said they liked tips. So this may be that my tips just weren't great. I didn't really come up with good enough tips, so that's also important to reflect on. But interesting that the facts were liked and if that impacted their outcome expectancy and risk awareness. So here's a graph of the sedentary behavior at pre, post, and follow-up. It's total hours of sedentary behavior. So about 8, 9 hours. That's lower than the 10 to 12 that's based on accelerometry data. That's kind of to be expected because it's self-reported. But there was no significant change, unfortunately. But that's not necessarily a bad thing. The in general, because sedentary behavior is associated with studying and exam-related stress, because my post and follow-up were nearing that end of semester crunch where there's final exams, we probably, if we had a control group, which I didn't have, we probably would have expected to see an increase in sedentary behavior to the end of my intervention. So no significance is not necessarily a bad thing. And as well, there is no significant change in non-sedentary break frequency. But you may have remembered at the beginning, I kind of talked about how it's recommended to break your sedentary behavior into 20 to 30 minute bouts. The bouts here are about an hour. So students are sitting for very long periods of time before they're standing up. And then physical activity. There was a significant change, but it is not the significant change that we wanted. So, unfortunately, physical activity minutes per week dropped significantly at follow-up compared to the pre-survey. But interestingly, this drop is 25%. In general, in a study that looked at Canadian university students, they generally see a 6% decline in physical activity. So this is substantially larger, and I'll come back to this at the end. All right, so was it effective? Possibly, maybe. If future studies use a control group to see that general trend here at UNBC specifically, this intervention could have maintained sedentary behavior lower than it would have been. And overall, the intervention was well received and retention was high. And the significant decrease in physical activity may speak to the specific context of UNBC. So those winter months, November, December, we saw that decrease. And so compared to the study that was done in the general Canadian students, it was generally urban universities that were used. So definitely a different context here at UNBC to keep in mind. All right, so future research, definitely use a control group and recruit from a more, oh wait.
Here's what I found on the web for definitely using
Thanks, Siri. Definitely use a more representative population. So try and reach those non-health programming students. And as well, revise based on the intervention evaluation. Maybe beef up those tips a bit more, as well as the readability. Examine the readability of the text. And I definitely think we should further investigate the potential of text-based interventions, because everyone these days has phones, everyone looks at them constantly, so it's definitely a tool that could be utilized. Questions?
Questions for Robin?
Now I feel really bad for the people I didn't ask questions to. So, I mean, you talked about how the UNBC context might be part of the reason for the decrease in sedentary behavior, and I agree, but I don't necessarily agree that it has to do with winter per se.
Yeah.
So I'm curious what other factors related to UNBC might have caused that.
Thinking about a lot that came up in the literature was just walkability and geographic isolation, particularly in more rural environments. And so just the fact that UNBC is so isolated here up on top of the hill, and it takes a lot to like go down to, say, the grocery store in College Heights. Right. It's not as like what's the word? There's not as much continuity as compared to more urban centers like UBC, where you can walk everywhere. So that may impact it.
I was just thinking of other places that other universities I've spent time at. Actually, so I went to Acadia, same place as Chelsea, and I mean, it's really small town, smaller than Prince George, but the university's right in the middle, so you can walk to a cafe in 5 minutes.
there's definitely perks to being at UNBC. Like in the summer, there's so many trails and stuff, but definitely there's winter months when it gets really cold and it's icy.
Yeah.
Students tend to kind of avoid that walking outside. Me personally. Yeah.
Anyone else have questions?
I'm wondering if it was intentional to choose the time period that it led up to midterms and that it led up to winter.
Yeah.
It'd be interesting to see if it would happen right after midterms or leading into summer, like if the results would be different.
Yeah, it would be hard to time it so all the participants were doing it like after midterm season because that varies between students as well. But definitely thinking about maybe even in the January semester when the weather is getting nicer. Compare that to the winter semester. That would be interesting. Did that answer
That's the question.
No, it's
Yeah.
Just, did you intentionally?
Did I intentionally?
Yeah.
I didn't really have much of a choice
Right.
in the timing of the project. I wanted to give as much follow-up time as possible because even 2 weeks isn't that long of a follow-up, but just due to the time constraints, it was most feasible.
Going forward, if you were to, want to run this again and give it a try, how would you go about getting feedback on your tips and, getting feedback about whether they're confusing or not?
Yeah, I kind of wish I asked more questions in the intervention evaluation, pertaining to the content of the text. So I think I would just, if I were to do it again, maybe try out different types of tips and see if that changes things. Because the tips I came up with were just kind of like, oh, this would be interesting. But see if maybe even going off feedback from students, do a little pre-survey about what kind of things would help them decrease their sedentary behavior. Use a little survey in the student population. That might be helpful.
Anyone else? Okay, awesome. So we have like a couple minutes if anyone has any final questions for any of our presenters today. In general, about the honors process even, for any students that are in the room. You can ask them anytime or you can ask in front of everybody if you want. If not, we can say thank you and feel free to come ask some questions. Well done to everybody. You've been fantastic honor students. It's been a privilege to watch you throughout the whole year. I'm sure your supervisors share a similar sentiment. And best of luck. We look forward to tracking your careers as you get scholars. All right, thank you. I'm sure Bree can take the lead. I don't stop sharing. I don't know how to end this.
Yeah, it is.
I don't need all of it. No, I didn't like video quality.
You guys want to get just a few guys? Just the video.
If you want them, and then I'll do one after. I'll be in a photo with you guys. This is right on time. Right on time, guys. Good job on time. I was proud of the time. I guess I'll erase all the